Good morning, everybody, and welcome to Tuesday Training. I hope you're having a fantastic week. As always,
we are live from Austin, Texas, right here at Insurance Syndicate headquarters. And man, we have a great show for you.
Good morning. Good morning. What is going on, man? It's time for a little Tuesday Training. Hope you guys are doing fantastic today on this lovely February. Wow, the weather is wild here in Texas. 2 weeks ago, it was 25 degrees. Yesterday, it was 85 degrees here in Austin. Standard, I'm a fifth generation Texan. That's just standard. Today, it's going to be like 75 again, partly cloudy, humid as hell. But that's Texas, man. I hope you guys are doing great. I have got a ton of news today. Lots of news going on, as should be expected in the Medicare space, especially with the new administration. A lot of people speculating. We've actually had some of their first efforts in this new administration in making some changes in the Medicare space. We're going to talk about some of that today. But I've got quite a bit of news that I want to run through. Also, I've curated some questions from some of the different Medicare groups around Facebook. So I'm going to run through some of those and kind of do some live Q&A on common questions that agents are asking out there in the field, so to speak. But we're going to dive in it. If you have any questions as I'm going through some of the stuff, man, drop them in the comments. I'll be happy to help you out, see what we can figure out, and learn some stuff today. As always, this show is brought to you by DFY. DFY is my CRM of choice. It is a white-labeled Go High-Level platform, probably one of the most widely used platforms in all of insurance, whether you're in Medicare, life insurance, P&C, etc. Seems like everybody's using some version of Go High-Level. DF1 is the one I use, and I was actually working in it yesterday deeply, working on some new conversational AI tools that I can use to manage and qualify my leads as they're coming in and make sure that unqualified leads aren't making it to my agents. And I can do all that with a really simple conversational AI bot that is built into DFY. So super slick, super excited, and we're going to be launching that to get some madness going. But until then, let's dive into some news. I've got quite a bit of stuff. This first one is actually not Medicare, so some of you guys might appreciate it out there that aren't in the Medicare space. But here we go. Boom, right off the bat. CDI, California Department of Insurance, says serious questions over State Farm's financial condition. You don't say. Over $1 billion in claims already, as the insurer is now asking the state for a 22% premium hike. Wow. So not going to dive through every word in there, but it says it's pretty simple. California's largest homeowners insurer, State Farm, has petitioned state regulators for an urgent 22% rate hike, a move that underscores the deepening instability in the state's insurance market. No surprise, obviously, right? I mean, those wildfires have been crazy. It happens way too often, unfortunately, in California. And now we've got, like right here, it says this latest wave of fires in Los Angeles has left 12,000 homes in ruin. And I don't know if you guys have actually looked into some of those home values of where those fires hit and wiped out homes, but we're talking like $1 million homes, right? We're not talking shanties and shacks. Like these are $1 million plus homes, $5 million homes that have gotten wiped out. And they've already paid over $1 billion in claims. And now they are asking for 22% rate hike. California already has, as this article notes, some of the highest premiums for home insurance, period, in the nation. And now they're looking at going up another 22% just for State Farm. But that is the key. And it says that the California Department of Insurance confirmed that it would review State Farm's application. State Farm's rate filings raise serious questions about its financial condition. And we all know this, right? We're in insurance. We know that, hey, if for the carrier to be able to pay the claims and pay its people that run its business, it's got to make a profit. How do they make profits? Well, they either fire people and thin cost, or they certainly raise premiums. And just like everybody should also know, carriers cannot, and that's why one of the reasons I like this article, carriers cannot just decide, hey, let's just crank up the rate so we can make more money. Like, as bad as the situation is out there, they still have to go to the regulators in California and say, hey, this is our financial situation. In order for us to remain solvency, be able to pay these claims and take care of everybody that we take care of, we need more money. We have to raise the premiums. And that's true regardless of the line of business that you're generally in, particularly health insurance, particularly property and casualty. If that carrier wants to raise the rates, they have to justify it with that state Department of Insurance. So crazy stuff going on out there, man. I certainly pray for all the Californians that have been dealing with this disaster. And I'm sorry to say that many of you out there are going to be paying lots more for your home insurance. But moving along, that's my little blurb out there for all you P and C. I struggle to even spell that, but I think it's P and C. I'm a Medicare geek, but there's a little blurb for you guys. Moving along. Trump sets a 10-to-1 target for deregulation. And what is that potential impact for healthcare? 10-to-1 target. We already knew that this new administration was likely going to roll back a lot of the regulation in different areas. And certainly for us in the Medicare space, we, in a lot of ways, are very excited about it because there is some extremely tedious regulation that makes it just really hard for a small business, a small agency, to operate efficiently and profitably, right? Not saying it's impossible. It's just more difficult, right? Because there's more systems we have to put in place, call recording systems, disclaimers, all these different things that we have to do that just adds friction to the sales and marketing process and adds increased administrative cost, administrative time, etc. So I'm super interested to see what some of these deregulations are, but I noticed this article just popped up that he has now set a 10-to-1 target. What does that mean? That basically means that for every one regulated rule they want to keep, they have to eliminate 10 of them. And this article kind of goes through it. I'm not going to dive into it hyper deep, but the executive order that he signed last Friday lays out a 10-to-1 policy whereby the administration will nix 10 rules, regulations, or guidance documents for every piece of regulation that it promulgates. In context, I can only mean that promulgates means further, approve, continue, which they would have chosen an easier word, but maybe I'll add that to my vernacular. But the move is a significant escalation from the deregulatory efforts from even the first Trump administration, where the aim was to slash 2 regulations for every one that they kept. The entire federal government has undergone a regulatory freeze since the inauguration, and the freeze lasts until March 20th. Once the Senate confirms a new secretary for the Department of Health and Human Services, the department can begin laying out items on the chopping block, and I believe that's exactly where we're at. Deregulation has always been a priority for Trump. In his first administration, he issued a similar executive order with the mandate of cutting regulations at 2-to-1, and ended up cutting at 5-to-1, and now he's pushing for 10-to-1. And he says a little takeout right here. Overregulation stops American entrepreneurship, crushes small businesses, reduces consumer choice, discourages innovation, and infringes on the liberties of American citizens. That's what the executive order says. It also contributes to the high cost of living, including driving up energy prices. So pretty interested. They don't go through any of the items that he is looking at currently, at least not in this article. In the Medicare space, I know we have some of our wish lists, right? Some of us would like to see the 48-hour scope rule eliminated. Some of us would like to see the scope of appointment rule completely thrown out. Some of us would like to see call recordings taken off the book, right? Or maybe we don't have to keep them for 10 years. Like, that's kind of asinine, right? What client is going to complain 9 years later about the Medicare enrollment that you did for them? and then we're going to have to go back and dig up that call. Like that's over-regulation, in my opinion. And it, just like it says here, over-regulation stops American entrepreneurship, crushes small business, and reduces consumer choices, and even discourages innovations, and more importantly, infringes on the liberties of American citizens. So everybody stay tuned. I mean, we're going to find out. Like, it's just a matter of time. But wow, a 10-to-1 target is massive, massive. And some of you might like, how can he do that? Well, you may remember, and this is something I've been chatting about for a little while off and on. You may remember back in, I believe it was June or July, the Supreme Court threw out the Chevron deference ruling, right? And that Chevron deference was like, hey, elected lawmakers, they're kind of busy. So what they're going to do is they're going to defer law interpretation and rulemaking to federal agencies like CMS, IRS, TABs. I mean, there's numerous of them out there. I think there's 420 some odd regulatory agencies in the U.S. So they would use these agencies for that. Well, now that the Chevron deference rule is thrown out, which now means that no one except an elected official is allowed to interpret the law and then create rules to enforce that law, right? That tees this up where now he can actually come in and run something like a 10-to-1 target for deregulation. So it's going to be wild, but it certainly could be excellent. I'm of the opinion that we have some great years ahead of us in the Medicare space. And this is definitely going to be one of those things that will reduce the friction and the administrative workload on our business. Moving along, lots of news, like I said. Headline says it all. Healthcare stocks rise after Trump vows to love and cherish Medicare and Medicaid. There's been a lot of people concerned, right? Because we know that conservatives like to reduce spending. We know that he has some extremely ambitious goals when it comes to reducing spending. And a lot of people were really concerned because two of the biggest programs that chew up our federal budget is certainly Medicare, Medicaid. They're way up there. They may even be in the, I think they're like top 3. I don't have that list in front of me, but they are super expensive. So we knew he was going to go after them in some form. And a lot of people, like if you go on some of these different social media platforms, Lord help you, please don't go onto Threads because it's nothing but negativity. But you'll see people freaking out that he's going to completely abolish Medicare, completely abolish Medicaid, Social Security, all of that stuff, which is just asinine. But that's, that's how it goes. So if you read this, I'm going to find the statement that he specifically says here. And it's right here. He says, we are not going to do anything with Social Security, Medicare, and Medicaid other than if we find some abuse or waste, we do something. But the people will not be affected. That's what he told reporters on Friday morning. And after that statement, we've seen a little bit of bump in some of the different healthcare stocks. Doesn't really go into some of those, and I'm not here to try to help you with that type of stuff. Actually, there's a few here. It says, a few gains on some of the different bigger ones like Molina and Elevance. But more importantly, I appreciate the fact that he came out and insured everybody. I kind of wish he'd done it earlier, but he's like, hey, we're not out there to gouge and take away from Medicare, Medicaid, and Social Security. Matter of fact, he says we're not going to do anything with it except cherish it, love it, and care for it. But we are going to go after abuse and waste. And if you've watched this show, if you've watched my Tuesday training show at all over the couple of years I've been doing this now, I talk about a lot of the fraud, waste, and abuse that happens in Medicare. Like we see a ridiculous number of providers out there, shady providers, right? Certainly not all of providers are like that, but there are some providers out there. I spoke about one a couple of weeks ago that had like a $20 million scam that they ran on Medicare. Like this is not new. Like there's a lot of providers, durable medical equipment providers, doctors, dentists, etc., that are running games against Medicare to pull the money out. And it is I would say it's probably in the billions, or at least $1 billion or more that's fraud, waste, and abuse that's out there. So I really do hope they go after it, and I hope they create some systems that can reduce that so that the money that Medicare has can be more effectively utilized properly without all of that. So nice to see that he's making that vow, and hopefully that'll give people a little more security. In that same vein, Fierce Healthcare put this article out. It says Moody's downgrades insurers' credit outlook to negative amid ongoing cost pressures. That actually is a bit of a misleading, well, not necessarily misleading, but it's a little misleading, I guess. But it says here, Moody's Ratings is downgrading the insurance industry's credit outlook to negative as elevated medical costs continue to batter payers. Moody's analysts noted in a report that spending in the commercial market, that's group insurance, right, alone is set to increase by 8% this year, the fastest rate recorded in 13 years. Spending in the individual market, meanwhile, is set to climb 7.5%, another increase that's higher than in recent years. Factors driving these spending hikes include inflation, prescription drug spending, and higher utilization of behavioral health. Based on those trends, Moody's projects spending in Medicare Advantage will also increase between 5 and 7%. We are changing our outlook on the health insurance sector to negative from stable, the Moody's analyst wrote. Although we'd expect EBITDA growth to remain in the low single digits, insurers will continue to grapple with medical costs in the excess of reimbursement rates for MA and Medicaid, while commercial coverage also continues to face high medical cost. Researchers even noted that premium increases are not likely to offset the increase in spending, especially given competitive pressures around contract negotiations with providers in the commercial market. Medicare and Medicaid plans can more nimbly make benefit changes to mitigate spending increases, but they're also likely or unlikely to fully shrug off these cost hikes. Oh, it goes on. Another factor to consider is the ongoing conversation on the Hill about the pharmacy benefit management industry, and the scrutiny could be credit negative for the companies that operate the big three PBMs, CVS Health, United Health Group, and Cigna. For example, the Patients Before Monopolies Act, which was a bipartisan support, would bar the parent company of a PBM from also owning a pharmacy business, dealing a significant blow to these companies if it were passed and signed into law. That is one I would definitely like to see. I think the vertical integration between healthcare insurance companies and providers also owning their pharmacy benefit manager, that's some bullshit. And there's another article that I've already posted in the group that we're going to dive into on that. So it's going to be interesting to see if they do this. The Patients Before Monopolies Act, which has bipartisan support, it's going to bar the parent of a company of a PBM from also owning the pharmacy business. There's also plenty of uncertainty around the Trump administration and the approach it may take to Medicare, certainly. The bright spot for 2025 is likely enrollment growth. Medicaid enrollment will likely remain flat now that the redeterminations have been completed, and the MA and individual market are set to grow. I'm going to say that again. The Medicare Advantage and the individual market, ACA, are set to grow. So even though some of this article sounds very bad because they're saying, hey, we're changing the outlook to the healthcare sector to negative from stable, it still shows that there's growth on the board. And for us as agents, that's a good thing. So we're going to have a lot of opportunity, and I'm super excited. So this sounds like a bit of a negative article, and it certainly is. I mean, if they're going to downgrade the industry to a negative outlook, that doesn't sound like a promising industry that you want to invite people into. But the truth is, as it states here, these two markets are very much set to grow. And it finally says at the end, the analyst said the outlook could return to stable if cost trends moderate and the regulatory environment proves to be benign, including an extension of premium subsidies for Affordable Care Act expansion plans. Further push into value-based models and digital solutions will be a driver of a more stable credit outlook. Further push into value-based models and digital solutions. What are they talking about there? Well, we already know that value-based care, accountable care organizations are growing rapidly, right? Companies like Oak Street, Suvita, WellMed, Village Medical, Harbor Health, all of those, they're growing like gangbusters. And there's also a lot of evidence, I'm also going to hit on that in a minute, that shows that those value-based models are reducing the cost to Medicare, or the cost even of the patients as well, the beneficiaries. Digital solutions, obviously your telehealth solutions, virtual care, etc. And that industry also expanding, right? So if those two models can continue their growth and push, then that could be a big driver that can bring us back to more of a stable outlook instead of negative. Moving along. Here's some good news, I think, personally. A bipartisan group, and this is the first bill so far that I'm aware of, at least, that this administration, the new administration, has started to push out that is specific to Medicare, right? He wrote an executive order on day one that eliminated the $2 generic script cost, right, and some research and development costs that they felt like were awry. But this is the only bill that Congress will get to vote on that is actually affecting or could affect the Medicare space. And if you, again, been following my show or you've been paying attention to the news in Medicare, providers and physicians have been getting hosed under Medicare for many years now. I'm going off of memory, but one of my recent shows, I pointed out a trend that I believe said something like over the last 10 to 15 years, there's been basically a 30% pay cut to providers under original Medicare. So, and it's continued to go down. Like every year, it seems like there's a small cut to doctors under original Medicare. And it's interesting to see if this comes around. I would like to see doctors get more money under original Medicare. For a long time, I've kind of been under the thought process that they're purposely reducing physician cost under original Medicare, physician reimbursement rates, in order to drive more physicians to accept Medicare Advantage plans, right? We've kind of seen that counterintuitive. I mean, it's been going, that has been a trend that I've talked about this. I actually have a CE class on it that I've done with NABIP, but we can go all the way back to, I want to say the balance, I think it was the Balanced Budget Act of 2001, if I remember correctly, that started this trend. And there's been numerous pieces of legislation over the years that has reduced Medicare or reduced reimbursement rates to providers under original Medicare, but increased reimbursement rates and increased funding under the Medicare Advantage world, right? So we've seen a little bit, I wouldn't say a full flip-flop, but we've certainly seen, like, if you go back to Medicare Advantage plans back in like 2014, or even certainly before that, but even around 2014, a lot of doctors just weren't taking them. Like, it was hard to find doctors unless you were in a very dense urban area that were prepared and ready to accept Medicare Advantage plans. Obviously, over the years, as it's blossomed, grown, funding's gone, et cetera, more and more doctors are accepting them now by and large. And part of that is, in my belief, is because they've continued to cut payments to doctors under original Medicare. But now we have a new law that they're ponying up, a new bill, bipartisan support on it, to cancel a scheduled, or I'm sorry, to cancel the 2.83% cut that started January. So there was a Medicare cut to providers under original Medicare that went into effect this January. Was a 2.83% cut in Medicare payments to physicians. So they want to reverse that. The new bill is called the Medicare Patient Access and Practice Stabilization Act. Now, in addition to cutting the 2.83%, it also proposes a 2% increase to physician pay, which would be exceptional for doctors under original Medicare, right? We still don't have a massive issue where doctors are rejecting original Medicare. Like, the last number I looked at is it's still more than 98% of providers nationwide all accept original Medicare, even with the payment cuts that they've had. Generally, the group of doctors that don't accept original Medicare, most of them fall in behavioral health, psychologists, psychiatrists, neuroscientists, et cetera. And then there have been some efforts to increase that group a little bit as well. But still, 98 to 99% of doctors all accept original Medicare, even with these payment cuts. If this bill passes, we may even see more doctors get back on board with original Medicare, right? We may see more doctors say, you know what, I'll go ahead and start taking more Medicare patients, because there are plenty of doctors out there that accept Medicare. They've got a great patient panel, but they're saying no more. I will not accept any new Medicare patients, right? I had to actually, and this was a mistake I made, I had to help a client out recently because the provider that I set them up with, there was a provider of their choice, the PCP, when I set them up on a United Healthcare MA plan, showed in network, like everything checked out when I looked at it, enrolled them. Turns out the only way they would accept that plan is if you're an established patient of that doctor, which this person technically wasn't. So we had to go find him a new PCP. So we may see some of that reverse in this regards in different ways. The federal government has until March 14th to act. So keep your eyes peeled on this one, and I will circle back as soon as we get some updates if this act is pushed through. I don't know what else might be in this act. I don't know if it's just, all it says in here is it talks about canceling the previous cut and then adding another 2% on top of it to help doctors make some extra money. And tons of arguments there I'm not going to dive into, but like the doctors, again, I'm just going to say it. I opened up this article with it. They've been getting hammered for the last couple of decades on Medicare cuts. So, you know, with inflation and everything, like we need to give them some money, I think. Moving along. We've heard about this one for a while, but Cigna is finally set to close on their big sale. $3.7 billion they are going to sell their Medicare Advantage business to HCSC, all teed up for Q1. Cigna executives said that the company is on track to close the sale of its Medicare Advantage business in the first quarter of 2025, in line with its expectations. The insurer announced plans to sell off its MA plans to Healthcare Service Corporation in January 24 in a deal valued at $3.7 billion. Chief Financial Officer Brian Ivanko said that all federal antitrust approvals have been received, as have all but one state approval, right? So if you don't know who HCSC is, that's the company that owns and operates Blue Cross. So basically Blue Cross is going to be taking over Cigna. I've asked this of Blue Cross and other people about this, and my understanding is that they will continue to operate these Cigna plans separately from their Blue Cross, that they're not just going to blend them in. I don't know. Things can always change. They might end up doing some crosswalks in the future. You know, we'll see what that holds for 2026. And it doesn't surprise me that Cigna's plans were as popular as they are this year. Cigna made some big changes in their plans to really make some enhancements. And I'm kind of the opinion they did it purposely to beef up their enrollment, beef up their income so that they can pad this sale a little bit. But it says here the business is on solid footing. We're tracking for attractive growth in 25 and ready to hand that off to HCSC. Cigna Group reported $1.4 billion in profit for the fourth quarter of 2024, falling a little short from their expectations, but still good stuff. So I'll get some of these articles in the group for you guys so you can check it out. And I got a couple of more, and we're going to dive into some Q&A real quick. This one I already posted in the group. Says it's an Optimum study that shows that accountable Medicare Advantage models reduce admissions and ER visits. So they're talking about accountable care organizations as well as value-based care providers, right? Like Suvita, like Oak Street, Village Medical, WellMed, Harbor Health, et cetera, et cetera. There's plenty of them out there. And I posted this in the group with some bullet points on it, and I'm just going to kind of read through it real fast. But basically says that Medicare Advantage patients who were treated in a value-based care model saw better outcomes than those treated in fee-for-service models. So in other words, if you're on a Medicare Advantage plan and you're utilizing a value-based care provider as your primary care physician, Suvita, Oak Street, Village Med, WellMed, et cetera, et cetera, et cetera, if you're using one of those, you will have a better outcome than if you're just going to a doctor under original Medicare, the fee-for-service model, right? Why? And we know the argument. I mean, if you've been paying attention, you know the argument. Value-based care providers bring value. The The whole push is on value per visit, not volume, right? Fee-for-service model is still relying on volume. So when you're a patient and you go into that space, you spend most of your time talking to the nurse. Doctor sees you for maybe 5 minutes, prescribes you something probably, maybe schedules you a follow-up, maybe sends you a referral and sends you out the door. Value-based care a little different. All of your care coordinators are in that one provider so they can more easily communicate. You'll spend more time with your doctor because it's not a volume play, it's a value play. So you might actually get to talk to the doctor for 30 minutes, 45 minutes, an hour. I've talked to some of these value-based care providers, and many of them have told me that the first visit is always the longest visit. Like for that patient, when they come in and it's their very first time at Suvita or at Oak Street or wherever, they're going to spend 45 minutes to an hour with that doctor learning everything that they need to learn so that doctor can really get in there and help them. So my only issue with this article is that, well, it's ran by Optum. Like Optum, this is like the FBI said, we did an internal investigation and found no wrongdoing. So it is an article or a research study performed by Optum, but it is what it is. Says that researchers led by a team at Optum examined claims data on nearly 5.3 million persons from years 2016 to 2019 across 20 different measurements and found that patients in accountable care models were 9% less likely to be admitted to the hospital and 9% less likely to visit the emergency room. The study found that value-based patients were also 22% less likely to be admitted to the hospital for concerns related to chronic conditions like COPD, asthma, and an 18% reduction in admissions related to hypertension. So the whole idea of value-based care is that I can coordinate everything right here. We can catch it early. We can prevent chronic disease, chronic situations. We can prevent hospitalizations, right? We can prevent emergency room visits. So we can bring down the customer's cost. We can bring down the burden on the plans. We can bring down the burden on Medicare. Theoretically, it should save everybody a little bit of money and increase the health outcome for the patient, for the beneficiary. That's the whole idea. And this article, again, is pointing to it that, hey, it works, even though it is their own internal article. In addition, patients treated in value-based models were 9% less likely to be from the hospital. I'd already said that. Why is it being redundant on that? Whatever. So it's the second Optum-led analysis on the topic, 22 analysis on patients they did as well. This latest analysis includes more than 15,000 primary care physicians and data from 35 plans. So this article is already in the group. You can check it out a little bit more. There are other articles out there. Kaiser Family Foundation put out a research study as well that also found the same thing, that said, hey, value-based care providers are actually increasing health outcomes and reducing costs. So it works. Moving along. I got a couple more. I'll try to get through these quick. And this one's a winner for all of the people out there that are naysayers about prior authorization and Medicare Advantage plans. You're in the business to deny care, yada, yada, yada. Kaiser Family Foundation just put out a new article that showed that Medicare Advantage insurers in whole, all of them, made nearly 50 million prior authorization determinations in 2023. 50 million. So if we know that there's 66 million people on Medicare, little over half of them are in Medicare Advantage plans. So that's 34 million, we'll say, plus or minus. Then that means they're getting about 1.25 to 1.5 prior authorizations per enrollee. Right? So theoretically, just based on math, every enrollee in a Medicare Advantage plan is experiencing at least one prior authorization when they're getting care, right? Virtually all enrollees in Medicare Advantage, 99%, are required to obtain prior authorization for some services, most commonly higher cost services, such as inpatient hospital stays, skilled nursing facility stays, and chemotherapy. This contrasts with traditional Medicare, where only a limited set of services, including certain outpatient hospital services, non-emergency ambulance transport, and durable medical equipment, require PA. We know what PA is for. It goes through it here. It's designed as a cost control measure, right? To prevent overutilization, to prevent overbilling from doctors, things of that nature, and certainly to prevent some of the shady doctors out there that are doing scams. But a few key takeaways. Medicare Advantage insurers made nearly 50 million prior authorization determinations in 23, reflecting steady year-over-year increases since 21. In 21, they had 37 million PAs. In 2022, they had 42 million PAs. And in 2023, they had 50 million PAs. Makes sense. Medicare Advantage plans are growing. There's more enrollment. So certainly PAs should go up. In 2023, there were nearly two prior authorization determinations on every average Medicare enrollee. I already talked about that just based on the math. Everybody is on the math. They're all getting at least one and a half. But here we go. Insurers fully or partially denied 3.2 million PAs, which is a somewhat smaller share than 2022, 6.4%. So 6.4% of all prior authorization requests in 2023 were initially denied. In 2022, it was 7.4%, right? So it's a little smaller. Again, but the same thing also holds true. Though a small share of prior authorization denials were appealed, most appeals, 81.7%, were overturned, right? So of the 6.4% that were initially denied, of all the ones that were appealed, almost 82% of those were overturned. It's pretty much on par with what it was in 2022, but the total number of denials was actually reduced a little bit. So that's some pretty good news, right? This is already in the group as well. I'm not going to go through the whole thing, but again, I'm going to tell you, you need to be following Kaiser Family Foundation if you're out there in the ACA and certainly in the Medicare space, because the amount of information they put out, the data, the surveys, the research studies, et cetera, is exceptional to help keep you in the know on the marketplace and what is going on, right? So good stuff. So out of 49 million prior authorizations, 3.2 million were denied. That's 6.4%. And that is fewer than in previous years. So great article. This is already in the group. You can go check it out. And I've got a couple more quick ones, and then we'll jump on. I talked about this a little bit ago in the deregulation side, but pharmacy benefit managers levy very significant markups on drug prices for a $7.3 billion payday. I had Norma Johnson on last year at some point talking about the Part D, the Inflation Reduction Act, some of the Part D changes, et cetera. And this is a big part of her topic that she talked about, was these pharmacy benefit managers that are marking up the cost that they're charging to the pharmacies that are also owned by them, that get passed through and so forth. So it's a racket, 100%. It's a racket, and it needs to be fixed. So I'm just going to hit this main article, or this main paragraph. It says the report revealed that the three largest pharmacy benefit managers in the United States, Optum, Caremark RX, and Express Scripts, significantly marked up the price of certain medicines, including for heart disease, cancer, HIV, pulmonary hypertension, multiple sclerosis, and more. This translated to a whopping $7.3 billion in revenue in excess of the acquisition cost of the drugs. So they're marking up the drug prices to the tune of $7.3 billion in excess revenue for them. Good for them, right? The FTC should keep using its tools to investigate practices that may inflate drug costs, squeeze independent pharmacies, and deprive Americans of affordable, accessible health care, and should act swiftly to stop illegal conduct. So I'm not diving into this entire article again because I'm running out of time, and I got some more stuff that I want to chat with you guys about. This article is in the group. You can check it out. But if there is something that definitely needs to be reformed, we have got to figure this out. And as this previous article says, on the deregulation side, they have something that they're working on towards that. And now I can't locate it real fast. But it's an article that I just mentioned, right? That they are going after them. So we'll see what happens there. Last one, and we'll dive into some Q&A. This isn't anything major, but Accolade expands virtual care to Medicare beneficiaries nationwide through their Plush Care direct-to-consumer offering. This is a virtual healthcare access site like telehealth, etc. But it's a pretty big company. They have a platform called Plush Care, and they are now accepting Part B coverage, and they're expanding it and making it accessible to all 64 million Medicare beneficiaries. And if you remember, I touched on this earlier when I talked about Moody's downgrade, right, to an outlook negative. And it said further push into value-based models, digital solutions will be the driver to push us towards a more stable outlook. So good news, we're on the right track, right? We've got major expansion in digital solutions. Here's another one being brought to everybody, right? We've got value-based care growing. We've got proof that value-based care works. So we should be headed in the right direction. We're going to have to see how this deregulation shakes down and what they do on these PBMs that are jacking up prices. Those are the main topics there. So with that said, I just want to dive into some Q&A with you guys. I've curated some questions across some of the different groups that are out there, and I'm just gonna whip them up here real quick and answer them as I go. See if we can get through all of them real quick. And we'll start with this one. Can you withdraw a new to Medicare app? I have someone that changed their mind and wants a different MAPD. So the client he's discussing or asking about is someone that's in their IEP, their initial election period. Can I withdraw their app? Yes, you can if it's before the effective date, right? So if I'm, for example, writing a new to Medicare app today, if I'm writing a new to Medicare app today for someone that say has a March 1st effective date, that's in advance, it's in the future, and they decide, hey, wait a second, no, I don't want that plan. I think I want this other one. No problem. Just knock out the new app. You're still before the effective date. You can submit as many apps as you want in those first 90 days. The last one before their effective date is the one that goes into effect. Now, after their IEP effective date starts, they get 90 days to test drive that plan in their little open enrollment period. And if they don't like it, they can make one more change just like the regular open enrollment period, right? So everybody in IEP, right, they get the 3 months before, they get the month of, they get the 3 months after. Those 3 months after their MA plan effective date is their own little OEP that they can use privately, test drive that plan and see if they like it. But if you're before the effective date, you don't even need to withdraw it. Just write another app. Pretty simple. Moving along. I know that if you are Medicare eligible at 65, you cannot remain on ACA. What about those who are Medicare eligible due to disability? Is it required that they come off of ACA? Yes. Yes, it is. Anytime you qualify for Medicare Part A for free, you will lose any subsidies that you get for ACA, right? And generally speaking, like, let's be honest, I think most of the Medicare plans are probably a little better network, a little better benefits than the average ACA plan that's out there. So truthfully, this should not be a negative. This should be a positive. I know there's some people, we run into them all the time here, right? They're on an ACA plan. They're probably paying $0 because they're getting subsidy, but then they qualify for Medicare Part A free. They find out they're going to lose their subsidy, and now they're going to have to pay $1,500 for that MA plan, right? But they're like, man, I'm paying $0, and now I got to pay $185 or whatever it is to move over to Medicare. So a lot of times they'll look at it as a negative, but ultimately it will be an upgrade in their benefits. But regardless of what your age is, doesn't matter if you're disabled, doesn't matter if you're over 65 or whatever, when you qualify for premium, this is the key, when you qualify for Part A, premium free, you lose your ACA subsidies, period, right? They want you on government health care, whether it's ACA with subsidies or whether it's Medicare. But once you graduate and you get Medicare Part A for free, your ACA subsidies are out. Now, if you don't qualify for Medicare Part A for free, if you're one of those people that would have to buy it, well, then you would not lose your subsidies. And you could make a choice. Let me stay on ACA or let me move to Medicare and kind of do some analysis there. This question popped up in a group. Of course, it wasn't my group because they would have known the answer to this if they've been in this group and paying attention. Who has a great 30, 60 day, 90 follow-up day campaign they don't mind sharing? Well, I do. And it's what I've been talking about most of this these last few weeks, right? Understanding how to contact your clients And I would say mine is 15, 30, 60, 90. Actually, mine is 1, 15, 30, 60, 90. It's 5 calls. Day 1, day 15, day 30, day 60, day 90. Right. And I would technically say not the 90th day. Like I don't want to call them on March 30th to find out that they hate their MA plan. And now I've got to shuffle super fast to get something done. I want to call them, right? I'm going to call them on day 1, January 1, for example, January 15th. I'm going to call them on January 30th. And then it's February 15th, March 15th, kind of like that. That's kind of my cadence, right? We will call them. We'll check on them. I've already told you the script. Hey, Ms. Jones, it's Tony. I helped you out with your Humana plan this AEP. Have you had a chance to use it? Have you had any problems when you're using it? Excellent. Most of my clients have the exact same experience you do, although some have experienced some higher out-of-pocket costs. You might remember when I went through the summary of benefits, I pointed out the 3 biggest gaps where you're on the hook for cost. I'd like to take a few minutes to show you how to bring those down to 0. And then you pitch them a hospital indemnity plan. Pretty simple. That's my game. How do you protect your business when you die? It's called succession planning. As a matter of fact, one of our group members, Keith Knabb, shout out to Keith Knabb, he just dropped a great article that talks about succession planning and how to plan for it, right? If you do not have a succession plan in place, you're missing the boat. And this is especially true if you are set up as a corporation, LLC, S Corp, whatever it might be. You should 100% have your succession plan documented in place in the event that you pass as the key person. Someone steps in and they know what's going on, right? Pretty simple. I'm actually working with a couple of people to get that prepared for Avila, right? The way that we want it. And we're doing it a couple of ways. Like we got Grace, my partner, my wife. We're doing key person insurance on her because if she passes, she's my number 1 salesperson. Like I'm going to need some of that revenue back somehow so that I can go hire more people to help her, right? Or wrap it up in a bow and sell it. I'm not sure. And then should I pass, like we have a succession plan that's able to put her in place or give her money to hire someone to come into place. So you got to put all that stuff together. So I'm working with I'm working with 2 different attorneys to put that together. One does wills, trusts, estates. So he's helping us with the will language of it. And the other one is just helping with the corporate side of it, so to speak. Moving along. Got some more. I have a client who delayed Medicare with group insurance and is ready to retire. But is there a way to request his Part A effective date not be made retroactive 6 months so that he can keep his HSA contributions? No, there's not. Rules are the rules, man. If you qualified for Part A at age 65 and you were maintaining group insurance and you would have been under a manual enrollment process and you did not enroll in Part A at all, and then you leave your group insurance and you had an HSA, unfortunately, sorry, they're still going to backdate your Part A to the original qualification date. And in some cases, I believe, pretty sure, you're going to have to pay back some of the income on those HSAs and even taxes on it. But they will not, absolutely will not backdate your Part A date to let you capture those contributions. The rules are the rules, unfortunately, and they don't like to bend on them. Next one, where can I check if someone has extra help already and what level, right? Do they have extra help? Do they have LIS, etc.? Where can I check that? There are numerous places you can check that. Numerous. United Healthcare's Jarvis site has a spot where you can check it. WellCare, you can call in and check it. Humana has a site on their Vantage portal. You can check it. If you're using Connecture, I believe Connecture even has it. I know Sunfire has it. I use Sunfire and look it up. It tells me all the time if they're Medicaid eligible. Tells me if they're in penalty status for Part B or Part D. Tells me what their LIS levels are. Tells me everything I need to know. So there are numerous places. You should not be in any shortage to get this information quick. You just got to have the tools, and chances are you probably already have the tools and just didn't know it. Next one, if an MAPD enrollee is receiving chemo on an outpatient basis, say like once a month, how is that charged? Have you looked in the summary of benefits? Maybe the evidence of coverage? It's all listed right there. We'll tell you exactly how it's charged. Generally speaking, their co-insurance is going to be due at point of service. But in pretty much every Medicare Advantage plan, I would say 90 to 90, higher than that, 95 to at least 98% of them I've ever looked at maybe 99.9%. They all charge 20% for outpatient Part B drugs. That includes chemo. So yeah, if you have someone that is struck with cancer and they're getting chemo, they're probably going to hit their MOOP pretty quickly on their Medicare Advantage plan, because they are going to be on the hook for 20%. I've only ever seen one plan that didn't charge 20. It charged 10% for chemo, and I thought that was wild. I don't remember which plan it was or where. I want to say it was like in North Carolina or somewhere I was looking at. I was like, hey, that's the first time I've ever noticed that. Everybody else charges 20%. But yes, they are going to bill them, and it's going to be 20% of whatever that chemo is. That's fairly standard on all the Medicare Advantage plans, which is why cancer insurance is so important. And if you don't know the math on cancer insurance, 1 out of every 2 people, once you get to age 65, ain't getting off the planet without cancer. And cancer, that shit's like luggage. You take it with you everywhere you go. Moving along. Last one. Is this the last one? Yes, this is the last one. Unless you guys drop some questions in there. I got one more. If you have original Medicare and have met the Part B deductible, will it reset when you get a supplement? And actually, no, I do have one more after this one. But yes, if you get original Medicare and you have met the Part B deductible, would it reset when you get a supplement? No. Because your Part B deductible is between you and Medicare. It has nothing to do with the supplement, right? I mean, if you have Plan F, it's going to pay the supplement for you, but that doesn't matter, right? If you have a Plan G, for example, this year, and you met your Part B deductible, say in the first 6 months of the year, and you've already paid it, you're $257, and you decide like, hey, I want to flip Medigap plans. The rates on this one have gone up, and you're clean enough to pass underwriting, and you do. You've already met your Part B deductible for the year, because that's between you and Medicare. It will not reset. It's already paid, taken care of. And then one final one. This is a question that pops up everywhere. Not exactly this way. And this was in the group. Shout out to the agent, because I know I really appreciate where he's coming from. And if you're a brand new agent and you find out like, oh, I'm going to get in the Medicare space, and how do I get involved? Like, well, you either go work for a company, or you have to go through a broker or an FMO to get access to the Medicare contracts, most of them at least. So everybody's always asking, hey, do you have any recommendations for a Medicare-oriented FMO? Well, there's numerous ones out there. And when you call them, they're all going to tell you how great they are, period. I'm going to tell you the same thing. Other people are going to tell you what their value adds are and what they can do. Ultimately, if you're an agent and you're looking for an FMO of any sort, I don't care if you're an established agent or if you're a brand new agent, there's one question that you have to ask yourself in order to find the right Medicare FMO for you. And that question is simple. It takes a lot of honesty. It takes some internal digging, and most people don't have the moxie or the honesty to be brutally honest with themselves. But the question is this: what do I need to succeed that I cannot provide for myself? Other than contracts. You can get contracts anywhere. And if contracts is all you need, shit, go get the best ones you can. I'm going to tell you, you should probably be buying in at the NMO level if all you need is a good contract, because that's where you're going to get the most freedom, the most opportunity for growth from a commission level standpoint, right? If the only thing between you is the NMO at the very, very, very top, then you can grow and fill up these other levels as you grow. But again, that question is simple. What do I need to succeed in this industry that I cannot provide for myself? Write it down. If one of those answers is leads, well, then you should certainly go find an FMO that's going to provide you leads, right? If it's not leads, you're like, no, I'm a marketer. I know how to generate leads. I know how to beat the streets. I know how to cold call. I know how to do that. Then again, ask yourself that question and figure out what it is, and then shop for the FMO that can meet those needs and compensate you accordingly, right? If you need someone to do ride-alongs with you and sales training, that's a whole nother level. Like that, you better honestly answer yourself and then go find an FMO that can actually do that for you, period. Like that's just the way it should go, right? So I'm going to say it one more time. What do I need to succeed that I cannot provide for myself? And then go find you a broker, FMO, upline, MGA, SGA, whatever you want to add to it, that will meet those needs for you and give you an opportunity for success. One of the other statements that's in here, he added, not Medicare and final expense. I just want to do Medicare. And I also really, because I ended up having a little bit of a conversation with this gentleman, and I understand where he's coming from. There's a lot of recruiting models out there in the final expense space, good ones and bad ones. There's a lot of them out there that really prey on newer agents and get them in a place where, hey, you're buying leads from us and then chargebacks and this and that. Like he had apparently already been down that road. So he had enough bad taste in his mouth from final expense that he kind of felt that just spilled over everywhere. But the truth is, if you're an agent in the Medicare space, period, whether you're selling Medicare supplements or Medicare Advantage plans, you're already talking to the exact same group of people that shop for and purchase final expense. So if you're not selling final expense to your Medicare people, you're shooting yourself in the foot. I built my entire original book of business as an independent agent doing just that. I didn't market final expense. And I want to be really clear. I didn't want to be out there marketing final expense and selling final expense to strangers. I wanted to market Medicare. I get a bigger return on my investment for leads and advertising by marketing Medicare versus life insurance, right? If you run 2 ads, you're generally speaking, you're going to get a smaller return on the FE than you probably would the Medicare, given everything's all the same. At least, and that's my opinion. And it's true, even it's definitely true in direct mail because I tried it. And then for everybody that bought Medicare products from me, I would cross-market final expense. Why did I do it that way? Well, I wanted to build up my Medicare renewals, number one, and I wanted to use final expense to inflate my first year commission so that I actually had money in my pocket and could afford things like cable and ramen, right? It was a way for me to get my business going and get it going fast. If I could write 5 Medicare apps a week and 1 final expense app a week, that was plenty of money. I could take all my Medicare money and keep it into marketing, and I could use the final expense commissions to pay my bills. Fairly simple idea, right? And the better part about it is if you're cross-marketing the final expense to your already established clientele that like you, trust you, know you, they're not going to cancel that FE product. They appreciate what you've done, right? These are people that are already loyal to you, so you're not going to deal with chargebacks, et cetera, right? Alternatively, you can always take your final expense commissions as earned. We do them on a 6-month advance at Avila. We don't need the full 9 months or even 12 months. So we just do a simple 6-month advance on those. Same concept. We market Medicare up front. Once you're an established Medicare beneficiary, we will come behind and market final expense to help you out because it is a product that you need, and then certainly grow our commissions. And you should not be timid or afraid of that model. So that's the show. That's the day coming up on the top of the hour. I appreciate you guys tuning in. Again, most of these articles are already in the group. There's a couple that I need to add, but you will see them there. And next week, stay tuned. We are going to have Caitlin Lemus Portillo on the show. She is an absolute genius and expert in SaaS development, software, whatever services. Can't even remember what SaaS stands for, but certainly in the Go High Level platforms. So if you're out there and you're an agent and you are using a Go High Level platform, whether it's DFY or Go Guru or Agent CRM or your own version or whatever it might be, tune into the show because we're going to go over some things in that platform that are going to be pertinent to you, whether they're new things, updates, tricks, tips, tools. We'll be going all over that next week. So we will see you then. Until then, have an awesome week and thanks for tuning in.